Good afternoon, everyone, and thank you for joining us. Welcome to today's ACCP Transplant PRN webinar. My name is Sabrina Sanchez. I am a transplant clinical pharmacy specialist at the University of Chicago, and it is my pleasure to moderate today. Today, we are excited to welcome Mary Grace Fitzmaurice, a transplant clinical pharmacy specialist and PGY2 solid organ transplant residency director at Henry Ford Health. She is also an adjunct assistant professor at the Eugene Applebaum College of Pharmacy and Health Sciences, as well as Paige Stratton, a transplant clinical pharmacy specialist at Henry Ford Health. They will be presenting on metabolic liver disease. In a moment, I will turn it over to Mary Grace and Paige, but first, here are a few quick notes. For our audience members, please ensure that your microphones remain muted for the duration of today's presentation. The mute button is located on the lower left-hand corner of your screen. If at any point during the presentation you have a question for the speaker, please submit your questions by using the chat functionality at the bottom of your screen. Please send your questions directly to me in an effort to minimize possible interruptions, and we will take questions at the completion of the presentation. Today's webinar will be recorded and posted on the ACCP Transplant PRN YouTube channel. If you experience any technical difficulties during the webinar that are not fixed by logging out and refreshing your internet connection, please make me aware through the chat functionality, and I will try to help if I can. Now, without further ado, I will turn it over to Mary Grace and Paige to begin our webinar.
Thank you. I'll just pull the slides up. Oh, no. Maybe click into this and all. One sec. Okay, I think we are all good. Can you guys see the slides?
No, we can't.
You can see them now?
I can see the slides.
Okay, perfect. Awesome. Okay, great. Thank you. Thanks everyone for attending our webinar today. We are going to be presenting on Metabolic Mayhem, the liver pays the price. Again, my name is Mary Grace and my colleague Paige is with me. We have no conflicts of interest to disclose, and we will be discussing both on and off-label use of medications during this presentation. Our objectives today are to review current MASLD guideline updates to assess pharmacologic management strategies and the role of pharmacists in patient care, to design an appropriate medication regimen and monitoring plan for patients with MASLD, and to develop tools to assist with medication access and insurance coverage of our new MASLD therapies. So to start, we will review the basics of MASLD, including pathology, epidemiology, risk factors, and morbidity and mortality. To start, what is MASLD? This refers to the presence of excess triglyceride storage in the liver in the presence of at least one cardiometabolic risk factor in the absence of no other discernible cause. In a few slides, we'll discuss what these risk factors are and what they look like. From a more like hepatocellular damage standpoint, MASLD refers to when there is greater than 5% or more of the hepatocytes display macrovascular steatosis in absence of a readily identified cause. This flow sheet is from the clinical practice guidelines that were published in 2023, and it helps to kind of use the flow of how to diagnose, or kind of, we'll talk about diagnosis more, but if a patient has a steatotic liver, how to progress through whether it is MASLD or other causes. Next, this diagram reviews the pathogenesis of MASLD. The pathogenesis is triggered by several mechanisms, and these mechanisms will be reviewed in a few slides, but these mechanisms cause energy intake to exceed metabolic demand. This then causes adipose tissue to reach max capacity of fat storage, inflammation, and insulin resistance, along with consumption of dietary carbohydrates. And these all trigger hepatic de novo lipogenesis, meaning that the liver is producing or is doing lipogenesis in an excess amount. So then this does cause buildup of free fatty acids in the liver, which sparks numerous stress and inflammation pathways that lead to hepatocyte damage, fibrosis formation, inflammation, and eventually fibrosis. To go over some of the strict definitions and nomenclature of MASLD, they have recently changed. As of 2023, MASLD has replaced the former terminology of non-alcoholic fatty liver disease, and MASH, metabolic dysfunction associated steatohepatitis, replaces NASH, non-alcoholic steatohepatitis. These definitions were kind of changed to rid of some stigma around like the word fatty and things like that. And then some of the other definitions to know are MASH refers to the presence of inflammation and cellular injury with or without fibrosis. And cirrhosis refers to when these bands of fibrous septa lead to nodules throughout the liver. Here at the bottom is a good diagram of the spectrum of disease, showing that first it just starts as mild inflammation as MASL, and then once we have the presence of inflammation with cellular injury, it is considered MASH. Once we're within the MASH category, patients can have fibrosis or not. We'll talk more about the scoring system of fibrosis later, which can eventually progress to cirrhosis. MASLD prevalence is steadily on the rise, especially in the United States. Globally, the prevalence has risen from 25% in 2016 to 38% at present, and this is expected to continue to rise. Also, people with isolated steatosis will progress to advanced liver disease at higher rates, especially in those who have type 2 diabetes, with 42 to 65% of these patients progressing to advanced liver disease. This upward trend is also not expected to stop. The incidence of MASH is predicted to continue to increase 2 to 3-fold by 2030. And I think this chart here demonstrates this expected rise pretty well. As you can see, the number of MASLD cases has climbed since 2020 and will continue to climb through 2050. And as shown by the differing colors, the cases of MASLD that are progressing to fibrosis are also expected to rise. I think this graph does a good job of demonstrating how both the incidence of MASH is increasing in MASLD, but also the severity is also increasing. MASLD is often associated with and preceded by several comorbid conditions. These conditions are important to identify and control because the greater number of these metabolic abnormalities, the greater risk of histologic progression and all-cause mortality in patients with MASLD. Firstly, hypertension is associated with progression to fibrosis, and patients with MASLD have a higher incidence of hypertension compared to the general population. MASLD patients are 2 times more likely to have lipid abnormalities, so it is important that these patients are monitored for dyslipidemias. MASLD is also associated with a 2-fold increase in CKD, and patients with MASLD have a higher prevalence of advanced fibrosis. So in patients who have MASLD and CKD, they're at higher risk of advanced fibrosis. And then as will be discussed a little bit more, type 2 diabetes is the most impactful risk for MASLD, fibrosis progression, and hepatocellular carcinoma. A few more comorbid conditions to review are obstructive sleep apnea, obesity, and cardiovascular disease. OSA has been suggested to be associated with more advanced MASLD. This is thought to be due to mitochondrial dysfunction, lipid and glucose dysregulation, insulin resistance, and increased hepatic lipogenesis. Obesity also causes inflamed and dysfunctional adipose tissue with impaired insulin signaling, which triggers MASLD development. And then lastly, cardiovascular disease has a very strong association with MASLD. So it's very important that these comorbid conditions are identified, whether you are working a patient up for MASLD or once a patient has MASLD monitoring for these things, especially as MASLD is on the rise. When we talked about those metabolic risk factors to help with that are in the diagnosis of MASLD, here is a good clinical practice guideline that outlines what exactly we're looking for. So the metabolic risk factors include overweight or obesity, type 2 diabetes or irregular glucoses, hypertriglyceridemia, HDL cholesterol abnormalities, and high blood pressure. This also outlines the exact criteria to help meet these, but also it is important to still consider those other comorbidities we talked about, such as OSA. What type of impacts do these risk factors have? These can have very strong risk factors on the progression of MASLD. As discussed, type 2 diabetes is one of the biggest, most well-defined and impactful risk factor for MASLD. It has a strong consensus that patients with MASLD and type 2 diabetes will have a much higher risk for progression to advanced fibrosis, cirrhosis, and hepatocellular carcinoma. There are a few other identified risk factors that include males aged greater than 50 years, postmenopausal women, and individuals with multiple cardiometabolic risk factors. These all create a higher risk for development of fibrosis and progressing to worsened advanced liver disease. With all these risk factors, patients can have different rates of fibrosis progression. So to start, patients who have minimal steatosis progress a bit slower. They are expected to progress approximately one fibrosis stage every 14 years. Once patients develop the inflammation and cellular damage, MASH, patients are expected to progress a bit faster at one stage every 7 years. As fibrosis progresses, the rate of cirrhosis and decompensation also accelerates, as you can see here. Patients with minimal fibrosis are expected to progress to hepatic decompensation and cirrhosis at a rate of within 30 to 35 years. Once patients have more advanced fibrosis, this is cut dramatically, with expecting to progress to cirrhosis and hepatic decompensation within 2 to 6 years. And then once we look at the fibrosis scoring as well, not only is higher fibrosis scores associated with higher rates of cirrhosis and decompensation, it's also associated with higher rates of liver-related morbidity and mortality. This diagram outlines the progression and development of MASLD. So basically, everyone starts with a healthy liver, but progression to isolated steatosis can occur at rates as high as 65 to 85% in those patients at high risk. So think back to those comorbidities and risk factors we discussed. Those patients could progress to isolated steatosis at rates of 65 to 85%. Isolated steatosis will then progress to MASH, and as fibrosis continually progresses, cirrhosis can develop, and cirrhosis can progress to hepatocellular carcinoma, hepatic decompensation, or both. Since we've been talking a lot about progression to hepatocellular carcinoma, we can now discuss the rates of this within MASLD. So currently, MASLD is the fastest rising cause of hepatocellular carcinoma, with the incidence rate increasing as MASLD progresses. Rates of HCC are 10 to 11 times higher in those with advanced fibrosis. In patients who do have HCC that require a liver transplant eventually, MASH is now the leading cause of the HCC etiology, accounting for 31% of HCC-related liver transplants in 2022. All of the MASLD mechanisms of impaired mitochondrial function, cell death, inflammation, insulin resistance, and fibrosis development also contribute to carcinogenicity, and other genetic factors can also play a role. With the growth of MASLD and how many more people are starting to have more advanced MASLD, MASH has become a leading indication for liver transplant, specifically in the United States. It has grown dramatically, with SRTR data from 2000 to 2022 revealing that MASH as the indication of liver transplant has increased from 9% in 2000 to 28% in 2022. And this has ranked it as the second leading indication for liver transplant behind alcoholic-associated liver disease. But with the expected progressions, it will likely become the highest or the most common cause of liver transplant, beating out alcoholic-associated liver disease. It is also currently the top indication for some specific groups of patients, including women without hepatocellular carcinoma, patients older than 54 years, and Medicare recipients. These trends mimic what is happening across the globe, but I think it is important to note that in other countries, such as in Europe, the trend is much slower, or the rate of increasing need for liver transplant for MASH is much slower. So the US is dramatically increasing compared to other countries. Lastly, the mortality of MASLD is important to note because basically as fibrosis progresses, it increases the mortality. All-cause mortality rate of MASLD is 17.05 per 1,000 person years, but as it progresses to fibrosis, this increases. Other things to know is that the cause of mortality is differing depending on exactly what the risk factors are. So patients who have cardiac specific comorbidities end up having mortality related to cardiac problems is about 5.54 per 1,000 person years. Extrahepatic rate is about 4.21, and those that have liver specific mortality is about 1.75 per 100 person years. As we discussed, these metabolic comorbidities, basically if a patient has more than one or has multiple, it increases the mortality risk. Those who have type 2 diabetes, as we discussed, being a very large risk factor, they have a 4-fold increase in mortality risk. Patients with pre-diabetes also have an increased risk of a 3.4-fold increase. Cardiovascular mortality risk increases as the severity of the liver disease increases. Now I will give it to Mary Grace to talk more about diagnosis.
So one of the first things that we are going to be doing during the initial evaluation is to screen for the metabolic comorbidities that Paige mentioned. Oftentimes this may be done in a primary care setting, not necessarily getting to the hepatology or gastroenterology specialists yet. Patients should be assessed for alcohol intake and determining if their alcohol consumption meets the criteria for moderate consumption, which can increase their probability of advanced fibrosis. We, of course, want to exclude other causes of liver disease and steatosis, so doing a very comprehensive workup prior to leading to the diagnosis of MASLD. And then as pharmacists, we also want to think about potential drugs with links to steatosis or steatohepatitis, such as amiodarone, 5-FU, irinotecan, tamoxifen, methotrexate, and as a lot of us transplant pharmacists would be familiar with, corticosteroids. Identification of patients is primarily trending towards shifting to primary care. Previously, I feel like a lot of these patients were obtaining a diagnosis once referred to a hepatologist for increased LFTs, but the shift is focusing more towards identification early. So treatment can be focused more on prevention of worsening of risk factors. So patients with pre-diabetes, type 2 diabetes, or at least 2 metabolic risk factors should have something called a FIB-4 test. FIB-4 testing is a calculation that can be done based on age, AST, and ALT, and their platelets. If the FIB-4 calculation is greater than 2.67, these are the patients that are considered as moderate or high risk. The nice thing about this test is that it, of course, is non-invasive, but is an excellent negative predictive value in excluding those patients who have advanced fibrosis. If the patient meets the score criteria, then they should be referred for secondary risk assessment, which may not be commonly as done in primary care, but rather at a hepatologist or specialist setting, which would be for vibration-controlled transient elastography, or what we may commonly refer to as FibroScan, which is one of the branded tests. Patients can also receive magnetic resonance elastography, or MRE, as well as an enhanced liver fibrosis, or ELF test, which is a blood test. These secondary assessments can really help guide after the initial FIB-4 screening to see if patients are more consistent with moderate or high risk fibrosis, in which they absolutely should be referred to specialty care. And a pharmacist pearl here that we wanted to start kind of trickling in throughout the presentation. It's important to be familiar with the FIB-4 score, FibroScan, MRE, or ELF tests, as we've noticed an increasing need for medication therapy approvals for these to be submitted with medication therapy approval. The FibroScan is an ultrasound exam that measures the stiffness and fat accumulation in liver. It is non-invasive, non-painful exam, and the results are measured in something called kilopascals. Normal liver stiffness is anywhere between 2 and 6 kPa. A higher number indicates a more severe fibrosis or potentially cirrhosis. And our pearl here for the FibroScan report is it often should be included with the initial prior authorization when you're submitting for medications that we'll discuss later, as insurances seem to be more increasingly requiring the kilopascal score and the FibroScan report to determine need or diagnosis of MASLD. We'll move into treatment modalities now, starting first with lifestyle interventions, which are often some of the most important things that patients can do. There are several things that the guidelines point to as part of lifestyle interventions across a wide scope of different specialties and treatment areas. Things like macronutrient consumption, weight loss, exercise, and bariatric surgery prior to medications are things that our patients are often referred to or recommended, but really should be in conjunction together as opposed to an individual strategy. There are a couple things that patients can do for liver protective behaviors that really should be done throughout their treatment, whether they're on medication or not. Things like macronutrient consumption, which I'll talk about briefly, of course, to avoid alcohol once the diagnosis is made. And then patients should continue to exercise if possible and focus on weight loss. There are a lot of dietary changes that patients can make once the diagnosis is made. We are lucky enough to work with a MASH-specific nutritionist here at our hospital at Henry Ford. But one of the most common dietary changes that our team will talk about is the Mediterranean diet, which helps to improve cardiovascular health and reduce liver fat as well. I've put a picture on the side of some of the things that patients should be included in every meal, like fruits, whole grains. They should be eating fish and seafood, nuts at least 3 times a week. And then trying to avoid, of course, red meat and sweets, which can increase the risk of liver fat. Coffee consumption is also something that's noted in the guidelines that can potentially help patients. Of course, this is not something that means that they should be having coffee with additional sugars and additives and flavorings, but really three or more cups of black coffee per day, regardless of how much caffeine is in the serving, will help or has been shown to reduce the risk for MASLD and liver fibrosis. Ultimately, the patient's goal should lead to a caloric deficit to help improve and optimize their weight loss. One of the pearls we wanted to add here was to include a dietitian or nutrition consult, if possible, in submission to insurance, as we've noticed that this has helped optimize approvals of medications a lot at our hospital when the insurance is able to document that the patient has been counseled on these lifestyle changes. Weight loss and exercise are a very important part of the patient's treatment plan after diagnosis. Behavioral medication specialists, dietitians, pharmacists, patient and family engagement to help address all of the social, economic, and lifestyle factors that play into weight loss can really help optimize the patient's ability to meet their goals. Exercise independent of weight loss is still helpful, and it can have both hepatic and cardiometabolic benefit as well. Moderate exercise 5 times a week with some strength training included is recommended for patients with MASLD. High intensity exercise may be needed to reduce fibrosis, but consistent exercise is linked to a reduction in liver fat. Weight loss at even 3 to 5% can improve steatosis. Most of our drug trials that we'll talk about later have targets of 5 to 10% weight loss, but even as little as 3% can help with steatosis grading. And then at least 10% of weight loss has been shown to be required to improve fibrosis scoring. Bariatric surgery can also be considered as a therapeutic option in patients who meet criteria for weight loss surgery, and it was shown to effectively resolve MASLD and MASH in a majority of patients. Our pearl here, again, is just including documentation of diet and exercise counseling in your provider's note or in the documents that you submit to insurance to help optimize approval for medications down the road. Now we'll go into what is our bread and butter as pharmacists, is to help with the pharmacotherapy interventions of this disease state. There are several medication classes that are available with demonstrable histologic benefit with patients with biopsy-confirmed MASH. However, the current only FDA-approved medications for MASH are semaglutide under the branded Wegovy and resmetirom or the branded Rezdiffra. However, vitamin E, thiazolidinediones, GLP-1s, GLP-1 and GIP receptor agonists, SGLT2 inhibitors, and our partial thyroid receptor beta agonists have also been shown to have effectiveness on MASLD. There are several available treatment options, most of which have been shown, or all of which have been shown to reduce steatosis, and only some have been shown to decrease fibrosis. So our most effective agents are probably the ones we're more familiar with using now, which are semaglutide and tirzepatide, which have shown positive improvements on both steatosis and fibrosis, whereas medications like vitamin E and pioglitazone, which are a little bit more out of favor now, have not shown much benefit with fibrosis, but will hopefully help decrease steatosis grading. There are several GLP-1 indications, and the list is really only growing. I wanted to go through this chart and kind of walk through the different medications, branded names and FDA approvals, as I think that's really one of the tools that we use as pharmacists, especially in our metabolic clinic at Henry Ford, to help optimize our patients' ability to get access to these medications. First, we have liraglutide, which is under the brand name Victoza and Saxenda. Victoza is FDA approved for type 2 diabetes and the reduction of major adverse cardiac events. Saxenda has the FDA approval for obesity, and these are given in subcutaneous injections. Semaglutide, which is becoming our most common medication used, are under the brand names Rybelsus, Ozempic, and Wegovy. Wegovy just recently received the MASH FDA approval, which I'll discuss a little bit later. And these medications come both oral and in subcutaneous injections. Tirzepatide with the branded names Mounjaro and Zepbound, with Mounjaro having the FDA indications for type 2 diabetes, obesity, and overweight patients with one weight-related comorbidity. Zepbound has the additional FDA indication for moderate to severe obstructive sleep apnea and come in subcutaneous injections. And then most recently this month was the new oral GLP-1 medication Foundayo, which was FDA approved for obesity or overweight patients in the presence of at least one weight-related comorbid condition. And for what qualifies as a weight-related comorbidity for approval, things such as type 2 diabetes, hypertension, cardiovascular disease, sleep apnea, and dyslipidemia, all of the things that Paige mentioned earlier in her presentation, can be used to submit for approval for these medications. One of our pearls here is that the indication matters. When submitting with the correct diagnosis code to the dispensing pharmacy, this will help improve authorization status significantly for insurances that otherwise typically have obesity meds as non-formulary. So if your patient has another comorbid condition that's weight-related or they have type 2 diabetes, approval can often be gained by using the medication that's branded as such, as a lot of insurances unfortunately have removed obesity as a clause under their formulary. We finally had our first FDA approval specifically for MASH, which was Rezdiffra. This happened in March of 2024. Rezdiffra received accelerated approval from the FDA for treatment of MASH with moderate to advanced liver fibrosis, consistent with that F2 to F3 fibrosis that we would know FibroScan. And this was based on findings from the Maestro-NASH trial, which we'll go through shortly. Rezdiffra is a partial agonist of the thyroid hormone receptor beta. And in the picture here, you can see by agonizing this receptor, it helps decrease glucose metabolism, decrease fatty acid oxidation, decrease cholesterol metabolism, and overall helps improve steatosis of the liver. The dosing is listed here, and this is the standard dosing based on weight in the setting of no drug interactions. We will discuss later dose adjustments related to concomitant medications that patients may be taking. There are no dose adjustments required for renal or hepatic impairment. However, this was not studied in patients on dialysis or use in decompensated cirrhosis, so it's avoided in those patient populations at this time. Rezdiffra is a substrate of 2C8 and is an inhibitor of OAT-P1B1 and OAT-P1B3, as well as a weak 2C8 inhibitor, which does have some important drug interactions that we will discuss. It has a Tmax of 4 hours, and the Cmax is decreased by about 33% with food. One thing to note is the thyroid hormone receptor beta is the major form of the thyroid hormone receptor in the liver, and stimulation of this receptor really helps reduce those intrahepatic triglycerides to help reduce steatosis. However, actions on the thyroid hormone outside the liver, including in the heart and bone, are mediated through a different receptor, which is the thyroid hormone receptor alpha. So this medication does not been noted to have significant effects on what we think of as our typical thyroid hormones or any hypo or hyperthyroid patients. Monitoring on Rezdiffra, as noted in the AASLD guidelines and in the package insert, recommends hepatic function panel, thyroid function, symptoms of cholecystitis, as this can increase your risk for gallbladder symptoms, and hypogonadism screening. The Rezdiffra can increase the SHBG by 2 to 3-fold, which can then exacerbate patients that have borderline hypogonadism. We have developed a chart here for you, which helps recommend monitoring for patients started on Rezdiffra to account for all of those things. So hepatic function should be monitored before treatment and then in 3, 6, and 12 months. Thyroid function should be checked before treatment and then at 6 and 12 months. Lipid profile should be also measured before treatment and then at 6 and 12 months. And then finally, non-invasive measurement of liver stiffness, such as a FibroScan, for example, should be done before treatment. And then if this was used or if this was completed before treatment, it can be repeated again at 12 months if you have a baseline to compare it to. And we have noticed that insurances have been requiring this repeat FibroScan at 12 months for continuation of therapy. And then if a more invasive test such as an MRI, PDFF was done at baseline, you can also consider repeating that at 12 months. Management of drug interactions is one thing that pharmacists should be heavily involved in for this medication, especially as transplant pharmacists. When Rezdiffra is used with concomitant strong CYP2C8 inhibitors, which is gemfibrozol, the use of Rezdiffra is not recommended. However, with moderate CYP2C8 inhibitors such as Plavix or clopidogrel, patients less than 100 kilos their standard dose of 80 milligrams should be reduced to 60 milligrams. And then patients greater than 100 kilos should be reduced from 100 milligrams down to 80 milligrams. We also have package insert labeling recommendations for maximum dose of statins, which we've listed here as well. So Crestor should be limited to 20 milligrams, simvastatin should be limited to 20, pravastatin and atorvastatin limited to 40. And we did want to note that previously the package insert did list OATP1B1 inhibitor, i.e. cyclosporin, as a medication that should be avoided with Rezdiffra. However, this has since been amended that there was no clinically significant differences in the pharmacokinetics of Rezdiffra observed when used with cyclosporin. Now, there's not much data at all on using Rezdiffra in patients who have recurrent MASLD post-transplant, but this may be a field of research that's expanding, and review of drug interactions with transplant medications will be extremely important. To assess the efficacy of Rezdiffra at 12 months, we should be looking at least a 30% reduction in the MRI, PDFF, or improvement in ALT as a favorable response. And then worsening liver stiffness, rising liver function tests, or lack of fat reduction may actually indicate that the treatment has not been as effective and discontinuation may need to be considered. I'll briefly go through the Maestro-NASH trial, which was the trial that led to Rezdiffra's approval. Patients with metabolic syndrome with 3 of those 5 risk factors that we've continued to talk about throughout this presentation, and then stage 1 through 3 liver fibrosis were confirmed. Notably, patients could not be on any other medications for treatment of NASH to be included. The endpoint was week 52 MASH resolution with no worsening of fibrosis and an improvement in fibrosis by at least 1 stage with no worsening of their NAFLD activity score. And this is just a score that ranges from 0 to 8, and a higher score indicates more severe disease. The results were relatively promising when compared to placebo. NASH resolution with no worsening of fibrosis was seen between 25 to 30% of patients in the Rezdiffra groups, compared to about 9.7% in the placebo. And fibrosis improved by at least 1 stage with no worsening of that activity score, around 25% in the resmetirom group compared to 14% in the placebo group. Notably, there was also a significant change in LDL in the resmetirom groups versus placebo as well. Resmetirom is relatively safe, with diarrhea and nausea being the most frequent side effects seen, between 24 to 34% and 12 to 22% based on the dosing. The typical onset was within 12 weeks of a drug initiation, but often within that first month after starting. The median duration of diarrhea was anywhere from 15 to 20 days, but it did not lead to a significant amount of patients discontinuing the medication. And the incidence of severe adverse effects was similar across both resmetirom and the placebo. One question that's posed in both the guidelines and that we come across in our clinic often is what to do with concomitant therapy. There's not great data to guide initiation of Rezdiffra when patients are already on a potential agent to treat MASH, such as semaglutide. You should consider the patient's comorbidities, response to their current therapy, their fibrosis stage, and then maybe any concern for further liver disease progression when considering adding on an additional agent. And thinking about what to do if your patient meets criteria for both. This is something that we also come across a lot in our clinic. We are often weighing the concerns for progressive liver fibrosis and the severity of their extrahepatic comorbidities. So is their diabetes worsening? Is their cardiovascular disease severe? Do they need potential weight loss for a possible future transplant listing? And then, of course, last but not least, is assessing their insurance formulary and which medications may be more likely to be covered. And then finally, semaglutide was approved for MASH based on the phase 3 ESSENCE trial. This included patients with biopsy-defined MASH and fibrosis stage 2. They received semaglutide 2.4 milligrams compared to placebo. This study looked at the resolution of steatohepatitis without worsening of their fibrosis, which occurred in 62% of the semaglutide group versus 34% in the placebo group. Secondary outcomes were also promising, with a combined resolution of steatohepatitis and reduction in fibrosis in 32% of semaglutide patients versus only 16% in the placebo group. And then, as would be expected with the mechanism of action of this drug, there was a 10.5% decrease in mean change in body weight with semaglutide compared to only a decrease of 2% with placebo. As a result of this, the AASLD guideline that Paige referenced earlier included an update to include semaglutide for MASH, and the recommendations are for patients with stage 2 to 3 fibrosis identified using something such as a FibroScan, MRE, or ELF testing rather than a liver biopsy, as it's noted that in the guidelines that liver biopsy is often unnecessary and invasive when not needed. Those with compensated cirrhosis who are receiving semaglutide for another indication should just be monitored a little bit more carefully. This medication has a favorable hepatic safety profile, and as I mentioned, the combination of medicines hasn't been studied. The reduction from baseline to 72 weeks of treatment did suggest significant improvement in MASH, as well as fibrosis improvement. And then the FDA took it one step further to recently approve semaglutide at 7.2 milligram injection. This has been termed Wegovy HD or Wegovy high dose based on the STEP-UP trial. This was actually done under something called the National Priority Voucher Program, which helps expedite approval of medications that address critical national health priorities, which, as Paige alluded to earlier, MASH is definitely, and obesity are definitely becoming a significant problem with the United States. And based on this trial, there was a significant change in body weight, and patients were more likely to meet their body weight reduction of 20 to 25% as compared to the 2.4 milligram dose of semaglutide. So even better weight loss and patients meeting their goals with the higher dose of Wegovy. And then for patients who may not want, we also have an oral GLP-1 that was just approved the first of this month called Foundayo. This was approved in combination with diet and exercise to reduce excess body weight and maintain weight reduction long-term in patients with obesity or that one weight-related comorbid condition. We have the oral dosing titration listed here. Similar to other GLP-1 medications, you titrate to response and based on how your patient's doing and their individualized goals. Next, we'll talk about monitoring of these agents once they're started on our patients.
So monitoring is important while they're on therapy or doing those lifestyle modifications. They should always be monitored for progression of their disease, or on the other hand, if their disease is getting better. So based on the FIB4 index that was discussed earlier, it kind of dictates how often they should be monitored. So people who are low risk, scoring low on the FIB-4 index, they should have it repeated every 2 to 3 years if they have no diabetes and less than 2 metabolic risk factors. And those with diabetes and 2 or more metabolic risk factors, it should be repeated more often at 1 to 2 years. And those in the middle category with an indeterminate FIB-4 index, this is when patients should be proceeding to some of those FibroScan or ELF testing. And if they are found to have a liver stiffness measurement of less than 8 kPa, they can follow in the primary care clinic for 1 to 2 years with surveillance, every 1 to 2 years with surveillance. And those are high risk. That is when they will be, should be referred to hepatology for advanced evaluation and start thinking about those therapies that Mary Grace just discussed. It is also very important to monitor patients' cardiometabolic status while they are, once they have MASLD, as we discussed, the comorbid cardiometabolic problems are what really can drive a lot of the mortality risk in these patients. So patients should have their weight, BMI, and waist circumference measured at least annually. They should have type 2 diabetes screenings annually at a minimum. As we have learned throughout this presentation, type 2 diabetes is a really impactful risk factor. So close monitoring of current diabetes and for development of diabetes is very important. Their lipid panel can be monitored per standard cardiovascular risk management guidelines, and statin therapy is safe and should be used in patients who have hyperlipidemia and those that do not, that have without decompensated cirrhosis. Blood pressure can be monitored per regular cardiovascular risk management guidelines, and they should be regularly assessed for alcohol intake as discussed. Once patients do progress to cirrhosis, they should have some extra monitoring as well. That kind of does match, other causes of cirrhosis. But firstly, they should have HCC surveillance done with a liver ultrasound with alpha fetoprotein every 6 months, and annually for all patients with MASLD. So once they have cirrhosis, it should be every 6 months. If they just have diagnosed MASLD, it should be at least annually due to the high risk of HCC development with MASLD. They should have variceal screening done, and this should be kind of monitored by the stiffness measurement and the platelets. If their stiffness measurement is less than 20 kPa and their platelets are greater than 150,000, they likely do not need an EGD, but if they hit those markers, it would be time to screen for varices with an EGD. Portal hypertension monitoring can be done as well. This correlates strongly with platelets. So if their platelets start dropping to less than 150 with increasing liver stiffness, they should have an annual transient elastography done. MELD scoring is important, especially when cirrhotic patients are hitting the area where they might need to be considered for a liver transplant. So MELD scoring is important to be done and should be done at least every 6 months. And considering liver transplant listing when MELD is greater than or equal to 15. And another important thing that we kind of talked about as well is if they need weight loss for liver transplant listing and using agents to help with that. And then monitoring, obviously, for symptoms of hepatic decompensation. Overall, kind of as discussed in a lot of the trials for these agents, monitoring for overall treatment response in patients who are on MASLD therapies or using their lifestyle modifications. The updated 2026 global consensus defines treatment response at 1 year as a 30% or more reduction in liver stiffness and a 0.5% or 0.5 point or greater reduction in the ELF scoring. So this is what can be done to see if they are having treatment response and if other modalities need to be considered. And then also monitoring for treatment response can be done by a lot of the non-invasive tests that we've already talked about. So ALT is well correlated to MASH. So a decrease in ALT can suggest MASH resolution. The FibroScan, like we talked about, in reduction on the liver stiffness measurement scoring will suggest fibrosis improvement. And then as talked about, the ELF scoring reduction will suggest fibrosis improvement. Now, we've kind of had these pharmacy pearls throughout the presentation, but we are going to talk a few more points, pharmacist pearls that can help you if you are ever taking care of these patients in the multidisciplinary setting. So firstly, this is just a reminder, a really strong role for the pharmacist with Rezdiffra is not only helping with approval of the agents, which we'll talk about in a few slides, but also watching for those drug interactions as talked about. So the limitation of statin doses, avoiding gemfibrozil, reducing the dose of Rezdiffra if they're on clopidogrel, and then the use of cyclosporin now not being something that has to be avoided. But as Mary Grace suggested, we do need further studies of using Rezdiffra post-transplant. Another strong area for pharmacists that can at least help or assist is in patients who are initiated on GLP-1 receptor agonists or GLP-1 GIP receptor agonists. In patients who are on these already for type 2 diabetes, it is important to make sure that we assess their current glucose lowering agents and diabetes control. So say they're already on insulin or metformin, and we're adding on one of these agents to help with their MASLD. They need to be monitored closely with their other anti-diabetes agents. So it's important at initiation of therapy to kind of consider their current glucose control on their current agents and what their A1C is. Oftentimes they may need empiric insulin dose reductions when starting one of these agents with closer monitoring of their blood glucoses. And this is often needed to be done in coordination with a primary care provider or an endocrinologist, depending on who the patient is already seeking for their diabetes management.
One of the rules that we can certainly help with, and we do in our clinic here, is with insurance authorization. I think it's been really important for us to review formulary and criteria for the FDA indication prior to prescribing. So considering if your patient has diabetes versus it's being used for obesity versus now MASH or obstructive sleep apnea. So for example, Medicaid does not typically cover medications for obesity in most states. And I wanted to put a pearl here. We've noticed that Blue Cross Blue Shield Anthem and PPO have been the only insurance providers thus far that have covered semaglutide for a MASH indication, despite the FDA approval several months ago. Letters of medical necessity have helped, especially if the patient has comorbid conditions where you can really use your pharmacist knowledge to help describe the risk of worsening comorbid conditions in the setting of MASH. And we've also noticed that insurances have been requiring reasoning that medications like pioglitazone have not been tried previously. So documentation of that can also be helpful. And then with resmetirom, we have noticed a lot of success with including imaging and lab work with the initial authorization, and also including documentation of diet and lifestyle modifications like we mentioned right for the get-go, as often the initial prior auth is denied if this is not documented. We did want to just show an example of one of our pages of our pharmacist protocols here at our Henry Ford Metabolic Clinic. This is an example of screening based on comorbid disease state with recommendations for medications. And then here's an example of something that we follow to help screen patients for use. So looking at medications like GLP-1s, where we're screening for diabetic retinopathy, medications like oral GLP-1s like Foundayo with the new approval. There are some additional dosing and drug interactions to review with patients and your providers. So this is a way that our pharmacist team has been able to be really integral in the management of these patients. And again, here's an example of our Rezdiffra protocol where we review indications. So we're making sure we're using it in the right patients, using it on label to help optimize approval. Submitting with the elastography if we have it, reviewing for dosing, drug interactions, and then we have a pretty standardized monitoring regimen where we check LFTs at baseline and then month 1, 3, 6, and 12, as well as screening for a thyroid test prior. And then we also do work a lot with the medication access program through the drug manufacturer Madrigal for patients who receive denial through their insurance to help get medication for free. And with that, we are happy to take any questions, but we appreciate your time today and listening to our presentation.
Thank you, Mary Grace and Paige. That was a great overview, and I'm really happy to hear that my coffee consumption is actually protective and reducing the risk of metabolic liver disease. For our attendees, just a reminder that you can put questions in the chat and I can read them off, but in the meantime, I was going to get us started. Something that I see as a transplant pharmacist is recurrent MASLD after transplant, especially with, using CNIs and weight gain from corticosteroids, as you mentioned in your presentation. I'm wondering, what does your center's approach look like for monitoring and managing recurrent disease in the post-transplant setting?
That's a really good question. And we've been discussing this a lot with our hepatologists too. So we are actually working on creating a group that would set up a, list of screening criteria for patients with either risk factors for recurrence of MASH or development of new MASLD after transplant to help get those patients referred to our liver metabolic clinic when either weight gain is noticed or it's noticed on FibroScan and biopsy to help get them better access and earlier access to care. But as of right now, patients are screened for any weight gain post-transplant, worsening insulin requirements, or if MASH is noted on biopsy or FibroScan. Currently, right now, we are targeting their comorbid conditions, so either obesity, OSA, or diabetes. So we've been using a lot of semaglutide for prevention of worsening fibrosis in our clinics, but we're working towards making kind of a better diagnostic screening for our hepatologists to refer those patients earlier. As we noticed, a lot of patients were getting referred to the hepatologist after they're at, F2 or F3, as opposed to referring early when they're maybe at F1 and need a little bit of assistance with weight loss or comorbid condition management to help prevent their progression.
Thank you for sharing. I'm looking to see if we have any other questions. All right, well, I don't see any other questions, so I think we will end our webinar today. Thank you again, Mary Grace and Paige, for that great presentation, and thank you all for attending. We will be sending an email shortly with instructions for obtaining CE credit. And as a reminder, this will be uploaded to our YouTube channel in case you want to rewatch. Thank you, everyone, and have a good day.